Comfortable there, just scoot across to another table, share, and then go back to where you're comfortable. Go.
And I would I'm very just so recently
Okay, please go ahead and thank your colleagues. If you haven't had an opportunity to share, you will as we go through the conversations this morning. Welcome to our plenary. We're going to talk a little bit about data. We're going to talk a little bit about health equity. I'm going to walk you through at the end of the session what you're expected to do. Just be aware that we'll start out here this morning, and then for the rest of the day, you're really in sessions. And I'll give you a little bit of an indicator about what that is before we're through here. But I want to get us started. We're on a tight timeline. I'm going to ask you to do your best listening and your best recording so that as soon as the presenters are through, you'll be able to bring your questions to the conversation in the room. So we have a plenary speaker this morning, and we have a panel that will occur after we're through. It is my great pleasure to introduce the speaker for this morning, someone who I'm sure for many in this room, you're quite familiar with the name. If you're not, then you should be. Dr. Ruth Petersen is the director of the CDC's Division of Nutrition, Physical Activity, and Obesity. And she has a significant amount of experience and leadership across multiple sectors in this issue as it relates to obesity. She's a physician with her MD and MPH degrees from the University of North Carolina. I know there are folks in the room who are celebrating that I said that. She's got a background in OBGYN and has done a lot in health services research. She's a very sharp mind and really trusted for her judgment on issues related to obesity. Will you please join me in welcoming as she comes to speak with us, Dr. Ruth Petersen.
Good morning, thank you, Chris. It's so nice to see all of you here. We do have a problem to solve. So I'm glad everyone at 8 o'clock in the morning is ready to do that. I, as Chris mentioned, am from CDC. Welcome to Atlanta. I am 7 MARTA stops away from this hotel at a wonderful building and facility that we call the Chamblee campus, where I sit in the National Center for Chronic Disease Prevention and Health Promotion, and then the division where I am, and I'll revert quickly to acronyms, DNPAO, Division of Nutrition, Physical Activity, and Obesity, sits with our sister divisions on that campus of cancer, diabetes, heart disease, and stroke. We also have the risk factors of Office of Smoking on Health and the Division of Population Health. So we are really happy to be here today to welcome you to this conference. And I want to share with you the balance here, that clearly everyone in the room is motivated to do health equity, and I'm so glad you're here, and motivated to address obesity prevention. And I want to talk a little bit about how hard it is to find the balance, because we have so many competing demands on the work that we're doing and our limited resources. So you'll hear that theme come out a little bit today as I talk. So first, just a little bit of background on who we are at DNPAO. I have to admit, I was the chronic disease director for almost 8 years in North Carolina, and I could tell you only about one of the branches in DNPAO, and that was the branch that provided program support to those states that had CDC funding. So actually, I've learned in my year and a half in Atlanta that actually there's an entire team of scientists and prevention specialists who were all at DNPAO leading the fight against the risk factors of nutrition and poor nutrition and physical activity. And again, we're part of the entire chronic center, so we're fighting obesity, and we're fighting diabetes, we're fighting all the other heart disease and stroke options that come from those adverse risk factors. So really, when we get up in the morning, and what makes us happy to come to work, as Chris is talking about, is how do we promote good nutrition, how do we increase physical activity, and how do we promote healthy weight. So DNPAO, as I will continue to say, is struggling with finding the balance for some limited resources, as we all are. So the question is, how do you pay attention then to health disparities? So one of the things that I'm going to continue to echo is that we use our data to find those target populations that have the highest disparities. And on this slide, you just see a couple of those examples. So certainly, you know, from the South, we have a geographic distribution of obesity that I'll show you in a minute. But we also have population groups and target groups that are more at risk for obesity. Non-Hispanic Blacks have the highest rate of obesity, followed by Mexican Americans. American Indians and Alaskan Natives are 50% more likely to have obesity. And the country here, the green country with the 71%. We now have data with our friends at Mission Readiness and Department of Defense that shows that many individuals, in fact 71% of young people in the United States, are not able to even apply to be a potential recruit in our military. 71%. Now there's 3 reasons for that. One of them is obesity, or I wouldn't be standing here telling you about this at this conference. But another one is actually a criminal record, and the third reason is they haven't completed their education that's required as the minimum base for that. So think about that as the influence of obesity prevention, especially in our rural areas. Mission Readiness is aware that many times youth only are able to have economic advancement and move out of rural areas where they're at risk for many, many, many challenges through military work. So we have a lot of work to do. So our goal is to help support America's journey to good health, and health equity is a constant driver that pulls our work into focus, which is true for many of you. So our data, again, is our compass to preventing diseases across the nation. We have a number of funding opportunities that we are grateful for that come from the congressional line items that we get through the leadership that we have in our Senate and House. And you will see these programs listed. How many of you in the room actually receive funding from one of these grant opportunities? All right, great. I see a few hands. Thank you for the work you do. Some of the greatest work we have right now is in what we fondly call 1305, the state actions to promote health across the country. And it's a compilation of diabetes work, heart disease and prevention work, nutrition, physical activity, and school health. But then we have other arenas that we have with more targeted focus, either on nutrition and physical activity, such as in our high obesity program or in our childhood obesity research demonstration projects. But we're also really fortunate to have the REACH program now. So that's been with us for almost a year, actually a year today, because it's the beginning of a new federal fiscal year. So REACH stands for Racial and Ethnic Approaches to Community Health. Are there any REACH grantees in the room at all? Right? See a couple hands. This is incredible work around disparities, around health equity at the ground level, really engaging communities and finding data on what the biggest needs are for those communities. It's a program that's been in existence since 1999, and it's made huge inroads in engaging communities and addressing health equity. And I know that you will hear from a couple of the individuals who work on that program in your program later. So, as you are aware, we have just released the 2016 BRFSS Behavioral Risk Factor Surveillance Survey data on the trends in obesity. And once again, the South continues to lead in the scary dark colors. So we do not see this trend reversing itself yet, even though we're all working very hard to do that. I do want to thank TIFA, Trust for America's Health, releases an incredible document when we put this data out that summarizes many of the advocacy, policy, other points around the obesity prevention work. So if you haven't seen the TIFA report, please check that on their website. So I want to show you this map too, because remember all the grants I just listed, 1305, 1422, high obesity reach, those sorts of things. States are competitive grants that states or communities can apply for. What you see here is a map, and the darker the color, that means the more sources of funding from that list of 5 these states or communities was able to get competitively from CDC. The point of this slide isn't that the dark states or communities have enough resources to do their work. The point is that even if you've competitively gotten all funding streams from CDC, and many of those are in the South, you still need to do a lot of work, and you still need to have more resources to do that, and we recognize that at CDC, so we try to pay attention to that when we talk to our friends at the national level. So where's our data leading us, and then where is the evidence leading us that tells us what we actually should do to make a difference? And again, you're here for a wonderful few days on learning about the evidence and learning about the things that can make a difference in the community, at the state level, in policy, at the ground level, in particular settings like schools and early care and education centers, and hospitals and primary care centers and FQHCs, and your planner and Smart Growth America and Safe Routes to School. All of these things are things I see in your program that you can learn a lot more about, and many of you have been doing those things, and we appreciate that. At DNPAO, we've organized our work into some buckets, I call them, to talk about our work so that really folks can understand the breadth and the depth of what we do. We don't do it alone. We have scientists, we have implementation scientists, we have prevention experts, but we really are there to support the work at the state and at the community level. So we look at this as a life course perspective attitude. But again, keep in mind that we can't do this without paying attention to where the data shows us the populations are the most at risk, or where we need to really put added efforts into making it equitable for health in those communities and states. So breastfeeding. Breastfeeding is one of our core functions for the beginning of life and a healthy start. Breastfeeding rates, thanks to the work that many of you in the room are doing and we're doing across the country, breastfeeding rates are increasing, which is excellent news. We've actually met 2 out of the 3 Healthy People 2020 objectives, and we just met a 3rd one the other day. So we're very, very excited about that. What we're not excited about is the disparity between African American women and white women is getting worse. So while we're making overall improvements, we're actually not improving breastfeeding rates at the same rate we're improving for African American women and white women. So that's how we always keep that filter on. So we're going to change up what we do to try to find those areas where more African American women are at risk for not initiating breastfeeding, or if they do initiate it, they'll stop early. So why might they stop early? Well, many of them have to go back to work within a week. I'm sorry, I've had 2 children. If you sent me back to work in a week, I would not be forming complete sentences. So there's a real problem with, again, picturing the bigger arena around this question. We can't just tell people to do something. We have to fix those things that are barriers to them initiating that positive behavior, not just for themselves, but for their children in the next generation. So early care, early child nutrition. There are not actual dietary guidelines for that 0 to 24 month period. And they're coming, and people and federal agencies are working tirelessly on getting that established. But guess what? We've got a lot of parents right now and a lot of caregivers with children between 0 and 24 who have to figure out what are the best complementary foods and what's the best way to approach transitioning from breastfeeding or from a bottle to something else. So we're working in that arena, again, with our grantees and with the people at the ground level who can help us identify what those barriers are. So we don't want children having Mountain Dew and Cheetos. We really don't want that. So what are we going to do to give them some other options and to change the policy around those environments? Which gets us into early care and education. Please go to those sessions on that. That's really an incredible leverage point for where we can change the eating for these children, and we can also change how they get their physical activity. So we're really excited about that area for intervention. I won't go through all of these, but please understand maintaining good nutrition and increasing physical activity is clearly some of the cornerstones that we work on. So again, you've seen our map about the obesity trends, and here's our vision. So we would like for things to get better. And we're really excited that you guys are all here to do that with us, and we're excited to actually help you meet the needs of those at the community level, of those at the state level, of those at the national level, in a mix of what we call this PSE approach, so policies and systems and environments. So it's not just telling people to do something differently, it's making their world something that empowers them to make those healthy choices. So I mentioned the balance at the beginning, and I want to come back to that balance. Everybody's busy. We all have 2 or 3 jobs. And what happens with our different hats is we get pulled in different directions. I'll give you an example. We get money from Congress, and Congress says, please tell us within 2 years the impact you've had on obesity. Okay, so that's my little balance over here on your left. Time-sensitive outcomes. If they have a multi-million-dollar investment in this country or in communities, what they want me to be able to tell them from all the good work that people would do who are grantees is how much did you drop obesity? How much did you improve nutrition? And how much did you improve physical activity? Okay, the balance on the other side is really the core of, as far as I'm concerned, addressing community needs, addressing health equity, engaging folks in what's really important to them. You have to build trust in these communities. You have to build trust with decision makers. You have to build trust at the state level. You have to have a relationship before you can do anything. So you've got to have time for that to happen, for coalitions to be built, or for coalitions to be informed again with the data that's relevant to them. If I give them the BRFSS data at a state level, they may not really feel like they're part of that state data. They may not feel that their community is represented. So how do we give them data in a way that's meaningful? Well, I can't do that in the 2 years that there's funding in a reasonable way and then show outcomes. So we all have this balance. So I'm just saying today, tomorrow, and the next day, please figure that out so you can go home and fix everything. Because this journey is not getting easier, but we are in this together. So I look forward to all of the things that you do. I wanted to point out we have some incredible health equity resources on our website. So please, if you go into DNPAO, you'll be able to find these at the CBC website. And I really appreciate this time. And I think we have a couple of minutes, Chris, if we wanted to, or if you want to do questions later.
Could you join me in thanking Dr. Petersen for giving us time? So we do have 2 minutes and 33 seconds. If you have a pressing question, otherwise what we'll do is we'll capture your questions, and at the end of the presentations from the rest of the panelists, we'll kind of make it all happen together. Is there a burning question? Somebody who says, I got up this morning, I knew I was coming here, I've had this question I've been carrying for like 30 years, and I'd like to have it answered. I might have set the bar too high. Thank you so much, Dr. Petersen. Thank you. We are on a tight timeline, and I'm very mindful that we have a few other presenters to kind of frame this issue with data and health equity in the work that you're doing. So, without further ado, I'm going to introduce Mary Bennett, who will then introduce the panelists for this morning. Mary is a community coach at County Health Rankings and Roadmaps. I must tell you that CHHR, in my mind, is probably the flagship program of RWJF. I don't know if there's anybody from RWJF inside here who would debate that, but I know they're very proud of the association that they've had with the University of Wisconsin. And Mary has made a lot of that work actually happen on the ground. In her role, she provides strategic guidance to communities that are looking to put the findings from the County Health Rankings to use, which means that she's literally providing them with her team with tools, technical assistance, and all that such as the communities will need to make it happen. In her past life, she's worked a lot with nonprofits, with nonprofit organizations. She's been in that world for more than 25 years, which means she knows what it is to actually be always trying to find the money to do what you need to do and to do it well. Could you join me in welcoming Mary as she comes to take the session to the next level, please? And I would invite the panelists to join her on the podium as she introduces.
Good morning, everyone. So I want to thank the Obesity Summit, Michelle and the whole team and all the volunteers that helped plan this program. I think that it's fantastic in our virtual world to actually get together, to have conversations. It's so important in terms of talking about what's working and what's not working, and where all of us, as was said last night, all of us have things to learn and things to share. So I have the privilege with my esteemed colleagues to give a really quick, and it is going to be quick, overview of our 3 sources of data for you. So I wasn't going to do a full bio on my fellow panelists, so I feel a little bad since Chris introduced me, but I'll just say that please refer to the program for the bios. So with me on the panel is Dr. James Holt, who is with CDC, and Jamie Kleinsorge, who's with Community Commons. And so the purpose is really to provide an overview of our data sources and how you can use them to empower your work. So I'm going to ask just a really quick question. So how many of you know about and use county health rankings and roadmaps? So quite a few, but not everyone. How many of you know about and use Community Commons? So this is good. Jamie raised her hand, I love it. And how many of you, in terms of the work of Dr. Holt, have used the data that CDC provides, which is such a huge support in communities across the nation? But how many of you are aware of chronic disease indicators in the 500 cities which he leads? How many people are aware of that? Okay, so here we go. Ready, set, go. In terms of hopefully giving you an overview of these data sources and how you might be able to use them. So I'm going to start out, and the first we have kind of 2 parts. One is to give the overview of our data sources, and then the second part is moving from data to action. And like Chris said, I work with a fantastic data team. I'm not the data geek. I'm the one that works with communities. So, but I work with the data a lot, but my passion is definitely in the community, making change, and I know how challenging and both how exciting that is. So first, as I said, focusing on the county health rankings. So we have the rankings and the roadmaps. The ranking is the data, the roadmaps is the how-to. So first focusing on the rankings piece. So just to give you a quick background, and again, this is kind of the speed session on giving an overview, but what we do is we first start with population-based data, which we use other sources of data. And what we do, and my brilliant data colleagues, I get to brag about them because I haven't done the actual data work, but they take that data with the motivation to help people use it in ways to draw attention, right? So what they do is package it in a way, and annually we rank the data of almost every county in the United States based on the broad factors influencing health. And so we package it, hopefully in a way that you can really use it so you don't get lost in the data, but can really pull things and lift it up to people's attention. I think it was Michael Sells last night who said, data doesn't lie. And so we need to tell the truth. So about obesity and about health equity of what's really happening. So we use this data and we do this annual release. So the release is working with community leaders and working with the media because we need media attention about this issue, right? We need people to know how serious this issue is. And we also need broad community support. So engaging the community in this release so that people get engaged in the issue, and of course then looking for evidence-informed strategies. You know, time is short, we need to use things that work, not just think of great ideas or what we think are going to be great ideas. We need those evidence-driven strategies or informed strategies. And then of course the goal is improve health outcomes, right? We want that for our communities and also within this framework of health equity. And I love last night when they said, you know, it's got to be health for all. It just has to be. So we have to expose the inequities and expose the benefits to the entire community by addressing health inequities. Whoops, where did I point this? So as many of you know, so I won't go too deeply into this, but we're defining health in the broadest sense. So we look at the 4 areas: health behaviors, clinical care, social and economic factors, and physical environment. And if you can see the slide, and I think these slides are all going to be available to you, you know this already, is that the truth of it is 40% is those social and economic factors. So the old days of thinking of health, you know, as the doctor's office or just health behaviors, you know, this history in terms of looking at the broader factors and how critical that is. So we're looking at policies and programs which drive these health factors. And then those health factors have this direct impact on the quality of life and the length of life. And we know that what's happening is people are starting to not live as long. And I think that's sobering. So I think it's important to think about and to use that, say, yeah, are you really okay that your children are not going to live as long based on the data because we're not addressing these issues that have impact on health outcomes. So just quickly, so you see that's our website. So when you go to our website, this is what you'll first see. And when you scroll down, you'll see the map of the United States. And you can click on your state, or either just by using the map or use the search feature to put in your state and your county. So here's an image of Georgia. Thanks for hosting us, Atlanta and Georgia. It's great to be here. And on the left, you see in green the health outcomes. and on the right, those health factors. And we think of that in terms of the health outcomes are today's health, and the health factors are tomorrow's health. So when you look at your data, it's important to think about that in talking with the community. So I'm going to just quick show you what we call the County Health Snapshot. You know, we all have this lingo, but it is a snapshot, and it's for that purpose. So if you see here, I don't have a pointer, but I did Rockdale, Georgia, because you see here that of the 159 counties on the far right, kind of above that green bar, of the 159 counties, Rockdale ranked 45 for health outcomes, so that's today's health. And then under health factors, and again, this is just a snapshot of the web page, the health factors is 63 in the ranking. So that means that Rockdale has work to do because it's kind of going the wrong direction, right? And so here, what's great about this data is you have the columns, which has what the Rockdale data is. Then it provides you with a comparison to US top performers. And that's really helpful. A lot of people in the community, and I see some nods, it's helpful to kind of know where do you stand in terms of top performers. And then the whole idea is that this county data is based compared to your state. So also where you stand in the state. So this, I'm not going to go into a lot of detail, but what I want to tell you is with each of these measures, you can click on whether it's adult obesity, food environment, under the health behaviors, adult smoking. You can click on that, you can find a quick summary of what is that measured. You know, because people are asking me, what are you measuring, right? And so you need to know what the measure is, what's the source of that measurement, what's the year of the data. That's important to know because there is a lag in time, right? Everybody wants to know, as Ruth was saying, what have you done in the last year and what's the impact? And that's very challenging. But in this, you can look at and find really valuable information, and you can always dig deeper on this website to find more information. So just as one example, the Food Environment Index, and I do have notes here, but I haven't looked at them. I'm sure I've left something out. There's two measures that I'm going to just quickly highlight. The Food Environment Index and also access to exercise, which if you look on our website and list all those measures under those four main categories, you'll find them. And so with the Food Environment Index, it includes both, the measure is, I'm gonna put on my glasses, is limited access, it has two parts, limited access to healthy foods, as is the percentage of the population that are low income and do not live close to a grocery store. And the second is food insecurity, which I know many of you are doing great work in this area also, which estimates the population without access to a reliable food, source of food, right? So we're looking at those two pieces, which when we're talking about health equity are so important. So it's not just availability, but it's also about the economic access for everyone so that people can eat more healthy. And in terms of access to exercise, this is just to get a little snapshot in terms of a little more digging deeper in terms of our measures. So we also look at individuals who reside in a census block within a half mile of a park. So looking at, thinking in that framework as far as a measurement. And then with urban census blocks, those that reside within 1 mile of a recreation facility. and in rural areas, census block, within 3 miles of a recreation facility. And I know some of you in rural areas are going, 3 miles, you must be kidding. But that, in terms of standardizing across the US, is helpful in terms of getting a sense of what's happening in your community. And so I'm not going to go into a lot of depth on these measures, but you can on the website look and see what the heck are those measures? What are they measuring? So what's the breadth of it? And how can I use this to convince others, to take this information to others, to sound the alarm, to say, this is something to validate the work that you're doing. So I'm not going to go into these details so we have more time, but this is how we develop the measures and the maps that we use to look at the information. But what I want to say is, in terms of the rankings, it really is, and this release, which happens in March every year, really is a great opportunity. And feel free to contact us, and at the end I have our contact information, because it really is an opportunity to leverage it as a media opportunity to talk about your fight in terms of obesity and also in terms of health equity. So it's a wonderful opportunity, so you can use this data, your county snapshot, to create a sense of urgency and importance in terms of the issue. Share the data with others. Get other people involved in the conversation about the data. Use the data to talk to elected officials. In some states, they send the data out to in Texas, to all the judges, the county judges. And we get more calls from those county judges saying, what is happening here? Or county officials. So it's a great tool, and you can contact us to get hard copies, as well as you can use the information on the web. So I'm going to turn this over to James Holt, and he's going to share his wonderful work with 500 cities and talk some about chronic disease indicators. And please feel free to write down your questions, because at the end we will have time for questions. So please feel free to jot them down.
Good morning. I'm Jim Holt from the CDC's National Center for Chronic Disease Prevention and Health Promotion, and I'm housed within Dr. Petersen's sister division, the Division of Population Health, specifically in the Epidemiology and Surveillance branch. I've been at CDC for 25 years. I'm currently the team leader for the Analytic Methods team, and our portfolio includes a lot of spatial analysis, mapping, chronic disease surveillance, and small area estimation. So what I'd like to do this morning is just a very brief presentation to give you an overview of 2 resources that we hope that you would find useful, and invite your attention to look at these websites at your convenience after the conference. But they have they're somewhat related, but they have 2 very different purposes, and the data are created in 2 very different ways. So I want to pay particular attention to those distinctions, and also tell how they can be put into practice at the state or local level. So the first resource is the Chronic Disease Indicators, or CDI, and the second resource is the 500 Cities Project. One of the main differences that I want to emphasize up front is the Chronic Disease Indicators are a state-based surveillance tool. So what we're publishing are state-level data. The 500 cities data for a large number of cities, 500 cities in the United States, are city and census tract level data. So moving on to the chronic disease indicators, the CDI is a collaboration really between 3 organizations: the CDC, the Council of State and Territorial Epidemiologists, and the National Association for Chronic Disease Directors. It really began back in the mid to late 90s. The first set of CDIs were launched in the very late 90s. They've been updated twice subsequently, most recently in 2013. And they really represent a recommended set of chronic disease indicators. They're not comprehensive. There are many other indicators that are of importance, but this is a good starter set for states to consider using for monitoring and looking at trends in chronic diseases and risk factors over time. A very unique aspect of the chronic disease directors, because it's a collaboration. We worked very closely with state partners. We had representatives in a number of state-based working groups to look at all our indicators, to recommend additions, changes to these indicators, and most importantly, agreement on the way that we define these indicators. So every chronic disease indicator has a uniformly defined a definition, numerators, denominators, data set, period of update, and so forth. So there are 18 groups, 18 groups of indicators, a total of 124 indicators. We have 201 actual measurements, because for many of these indicators, we report them for different at-risk populations or denominators. Of interest, perhaps, to this assemblage, we have 37 indicators specific to nutrition, physical activity, and weight status. There's an eye chart at the bottom. I didn't want to go through every particular indicator, but if you go to the website, they are all grouped by category. They're very easy to find and expand the definitions for the 37 indicators for nutrition, physical activity, and weight status. We provide both crude and age-adjusted rates. So there's really two websites where you can go to explore these data. The first is our CDI homepage, that's listed at the top, where you'll be able to access background information about the chronic disease indicators, a lot of detail about each indicator themselves, indicator definitions, and on that interactive website we have charts, tables, and interactive maps. The bottom resource is our chronic disease data portal. That is where we encourage data users to access our data in open data format. So if you're an epidemiologist, a statistician, a data IT person who really wants to explore and query the raw data, this is really the better place to access the data, to query and download the data. So there's really two places you can access it. They're linked to each other, and the data will be updated probably in about 3 months. We update our data on an annual basis. The most recent data we have related to obesity from the Behavioral Risk Factor Surveillance System are the 2015 data. The public 2016 data came out just recently, and we're working very hard to update all our chronic disease indicators that rely on the BRFSS, which is about 40% of our indicators. So potential uses for CDI. We're hoping that these data serve as an initial source of information for a wide range of chronic disease, risk factors, and health outcomes. We have risk factor data, we have preventive service use data, we have mortality data, we have morbidity data, we have hospitalization data, and we have about 22 of our indicators that are specific to policy systems and about environmental factors. Users can explore and download maps and graphs. We've heard that these could be useful and have been useful for state burden reports or needs assessments. And the data can also be a ready accessed source for performance metrics. Other questions that we hope that these data can address are how does my state perform on multiple indicators? It's very easy if you're from one particular state, say Alabama, for example, to just go in and look at Alabama data specifically across all 124 indicators. If you're with, say, a diabetes program and you want to look holistically at the nation or a particular region on diabetes-related measures, you can look for geographic variation in one or more particular measures. This also helps identify high needs areas. And starting last year, for the first time in chronic disease indicators, we were able to stratify and publish data by race, gender, and ethnicity. So that helps to inform program managers and decision makers about potential disparities at the state level. So that's the state level picture. I want to talk for just a few minutes about how we get down below state level, and more specifically below county level to cities and neighborhoods. So we were very fortunate about 2 years ago, or 2.5 years ago, to establish a working collaboration with the Robert Wood Johnson Foundation and the CDC Foundation. We were funded through RWJ and CDC Foundation beginning in October of 2015 for a 2-year project to provide small area estimates for the 500 largest cities in the United States at both the city level and the census tract level. For those who may not be that familiar with census geography, census tracts are somewhat analogous to neighborhoods. They generally have about 5,000 to maybe 8,000 persons in census tracts. They're defined by the census. They change about every 10 years after the decennial census. So this is a really low level of geography. And just as an example, the city of Atlanta has well over 100 census tracts. So it kind of gives you a sense of the magnitude of the number of census tracts and maybe the size that they represent. The map at the bottom of the slide is just a location map. It represents where these cities are. There's always an asterisk by 500 cities. And the simple explanation for that is if we use the 2010 US population, we go down to the 500th largest city, there are 3 states that don't have any cities in that membership list. So what we ended up doing was taking the largest 497, and then we took and added the largest cities for the states of West Virginia, Wyoming, and Vermont. So thus we have 500 cities. What this really represents in terms of population and burden is about 103 million US adults, which is 1/3 of the total US population. As I'm sure you're all aware, the US population is overwhelmingly concentrated in cities and urbanized areas. So our goal was to provide high-quality, small area estimates for 27 measures related to behavioral risk factors that influence health status, health outcomes, and preventive service measures. And we're leveraging, again, the behavioral risk factor surveillance system. And this is a theme that is common through many of our surveillance activities at CDC. The BRFSS, for those who may not be familiar, is an ongoing state-based landline and cell phone interview survey. It's conducted by the states with funding and support and technical assistance from CDC. It's been around now for well over 30 years, and it really forms the core of our state-based surveillance in chronic disease. For chronic disease indicators, we simply can compute direct survey estimates from the data. For the 500 cities, we have to be a little bit more creative, and we're actually using statistical modeling to create our small area estimates. So the estimates for each of these resources are created in very different ways, and I'll talk about the limitations for the small area estimates in just a moment. Our vision with 500 cities was to take the snapshot that we have available through the BRFSS, and this top map is just simply from the chronic disease indicators. This is obesity for 2014. So we take that state level understanding or picture of a particular risk factor or health outcome, and we wanted to move to also have some better understanding at the local level. The map at the bottom is the city of Atlanta. This is the census tract level map. We're also depicting obesity in this map, but this is at the census tract level. So a couple of things that you can see from just this one visual is that there's a great variation in obesity prevalence at the local level within the city. And the other thing that's hopefully very apparent is there's very stark geographic clustering of these rates. So if you were a program official and you're working in obesity and you want to know where are maybe my high needs areas within my area of interest, these data and this type of visual, this map, can help point you in that right direction. So I'm going to talk just a little bit about how we make this happen through small area estimation. This is not a statistical slide. I promise I won't add any of those. But we have a problem when we collect survey data. The BRFSS is a tremendous resource, but it's still limited in the number of samples that we can collect. Even when we approach 500,000 samples at the national level, there's really no way that you can have enough samples at a city, or more than maybe a couple of cities, but certainly not at the local level, to compute reliable direct survey estimates. So we employ a statistical technique. It's part of a family of techniques known as small area estimation that enable us to predict what those prevalences would be at these small levels, where we either have small or no samples. There's a lot of approaches to small area estimation. Ours is really just one, and I have a couple of references in my last slide if you want to read further, if you're more statistically inclined, if you want to read about the methodology and the validation, those citations are available. But essentially, what we're doing is we're statistically modeling the expected risk of health behaviors or conditions for 208 demographic groups that are defined by age, gender, race, and ethnicity, and further adjusted by where they live, based on their state, their county, and their neighborhood. The primary ways that we hope these data will be used is to inform development and implementation of effective and targeted prevention activities at the local level, to help identify emerging health programs and establish and monitor key health objectives. So the caveats, these are 500 cities. These are the statistically modeled prevalence. We really can't model the effects of local interventions. So I know a lot of the work that you do is program interventions. Because we can't model that, we really don't recommend that you use the data to evaluate the effectiveness of programs. And just to give you an example of what I mean by that, if you have let's talk about smoking, it's a little bit different program, but if you have a smoking cessation program at a local level that is effective, our model is going to model that predicted level of current smoking without taking into account that program intervention. So if you were to use these data, say from year 1 to year 2, it may not look as though that program actually is having any effect. So we simply can't include it in the model. So really, these data are more for program planning and to better understand the likely variation in magnitude of a health condition within your area. So just in summary, just to compare the two resources one more time, the chronic disease indicators are state level, they're annual, they're updated every year. We do have stratifications for gender, race, and ethnicity. They're direct estimates. So these are the data that you're very used to seeing through CDC's programs. I know that the Division of Nutrition, Physical Activity, and Obesity publishes their data annually. The BRFSS also publishes their data annually. These are data that you're used to seeing. And we have 124 indicators to look at. So even though there's 37 that may be directly related to obesity, I invite you to look at many of the other comorbid conditions and other risk factors that are on the CDI. The 500 cities is really new. So this is city and tract level estimates. They're annual. We published our data back for the first time in December of last year. We will be updating the data within the next 2 months, most likely, certainly by the end of calendar year 2017. We cannot stratify just because of the modeling and the sample size. So what you're seeing is just the overall prevalence for the population in those areas. And we have 27 measures. Of course, we have obesity, we have no leisure time physical activity, but we have a number of other related measures that I think would be of interest to obesity prevalence programs. Some references for further reading. I understand that you do have the slides, so you can refer to this after the conference. These are our websites. I did not list my email address, but I'm happy to give that to you. It's JGH, and then the number 4, JGH4@cdc.gov. It's JGH4@cdc.gov. We also have a 500 Cities mailbox. That's 500 cities@cdc.gov. We monitor that box, so either of those email addresses will basically get to me, and I'll be happy to answer your question, either about chronic disease indicators or the 500 Cities project. So with that, I will turn it over to our next speaker, Jamie.
Thank you. As Mary mentioned, we're like speed dating this morning when it comes to talking about our data sources, so I'm going to try to go through this as quickly as possible. I was so glad to see so many hands raised when she asked how many of you are using Community Commons. I hope by the end of this conference, everybody's hand goes up that you're using all of these data sources. We are all very valid data sources. Not one is better than the other. And so I just kind of wanted to mention that although Community Commons hosts county health ranking data and 500 cities data and CDC data, we're all useful in different ways. And so hopefully you'll be able to find uses for each of our sources as you think about strategies to improve obesity and health in your communities. So I'm Jamie Kleinsorge. I'm a project director at the Institute for People, Place, and Possibility. That's one of the 3 organizations that help powers Community Commons. We're also partnering with Community Initiatives, which is an on-the-ground facilitation and community strategy development firm, and then CARES, which is the Center for Applied Research and Environmental Systems. We have lots of acronyms, and you guys live in a world of acronyms, so you know what that's like. But CARES is at the University of Missouri, and they are really our technology backbone. They collect all of our data and work with primary and secondary data sources around the country in order to feed into our engine. So a little project for you all. If you ever get bored during our presentation, just count the number of times that we say data. It'll be extraordinary. They've done a great job so far, and I'll just add to that. So what is Community Commons? For those of you who are not familiar, we are a website. We host both community health needs assessment tools as well as mapping tools, and then we have a very large data warehouse. Really encompassing all of that, though, is we hope it's a place that you will go to get inspiration, to get data, to find sources of information, and become change makers. And so whether you are doing a community health improvement process or you're just trying to look at, access to recreation opportunities in your community, Community Commons is a place you can go to either get started or to finish a project. We work with a lot of different groups. This is just a small example of the types of organizations that we work with. So we've partnered with the CDC in the past to do a lot of projects. We work with a lot of community action agencies and the National Community Action Partnership, American Heart, Kellogg, Robert Wood Johnson, so a lot of our usual culprits. We do work with a lot of small public health departments, though, in communities that are interested in getting custom tools or custom data through our system. So all of these folks, the reason that we have this slide, though, is that everybody who invests in Community Commons invests in you and invests in the data that we're able to provide. And so all of our resources that you're going to see today are free, and it's because these types of organizations help fund these tools and the access to the data that we have on the site. So a couple of ways that you can use Community Commons. We're not just focused solely on community health needs assessments, though that's probably the main reason or the first initial reason that people come to Community Commons is to do community health needs assessments. But we also have a comprehensive community needs assessments tool that was sponsored by, again, that Community Action Partnership. So looking at communities more broadly rather than just health needs assessments. I noticed that Dr. Holt was saying they have 124 indicators. Well, we have 137 in our health needs assessment, so if we're counting, here. But those 137 7 were developed back in 2012 after the ACA came out and we had regulations around community benefit for nonprofit hospitals. But those were identified as the core health indicators that you needed to look at in order to do a community health needs assessment. That doesn't mean that those are the ones that you're going to use, but they are a really good place to start if you've never done or you're trying to start a community health needs assessment from scratch. We also have some tools that will help you identify vulnerable populations and gaps in service. As was mentioned by Dr. Petersen, looking at vulnerable populations is very important when it comes to doing obesity prevention and really just community health work anytime you're trying to do policy, system, and environmental change. Identifying those vulnerable populations should be one of your first steps, and so we have a tool that will help with that. One thing that we often tout that Community Commons can also do is help with grant funding. So if you're ever writing a grant, grants come in all shapes and sizes, but a lot of times they ask you, who are the populations you're going to serve and why are they in need? And so you can come get that data and you can get maps to support the statements that you're making in a grant on Community Commons. And so that's something that could set you apart in terms of a grant application if you have a nice map that came from our site or from these other sites to support your justification there. So just general data visualizations as well if you're doing a community and economic development or advocacy work. We also have some tools that allow for you to network with others and learn from others. We have a nice map gallery that you should check out if you're looking for inspiration or if you're not sure how to make maps. That's a great place to go. And then program and strategy evaluation. It can also be done on the site. So just a few things. We do have over 20,000 data layers available on Community Commons. So although we are focused mostly on health, we realize that there are other social determinants that factor into overall community health. So we do have civic and social, lots of demographic data, so any race, ethnicity, age, gender, those types of breakouts are available. We have lots of economic data, so we get data from like the Bureau of Labor Statistics and community development finance institutions, those types of organizations that you can bring in. The IRS also gives us a lot of data. We have education, educational attainment, graduation rates, free and reduced price lunch, those types of things. Environmental data, so if you're looking for floodplains or if you're looking for locations of disasters, those types of things, that's all available to you. And then obviously we have just lots and lots of health data, so health behaviors, health outcomes. And so you can search our database. We have it broken down by this taxonomy that goes through kind of topics, but then we also have all of the data sources available in another list. So if you're looking for something specific, like for example from the USDA, you can look directly at the USDA sources that we have. So one of the things that we try to do, if you've ever seen me present or any of my other colleagues present at a training, we use this term democratizing the use of GIS. So GIS is Geographic Information Systems, and it's a fancy way of saying making maps. And typically, in order to use some more sophisticated software to make maps, you have to have a degree or you have to have lots of training. And what we've tried to do is we've tried to simplify that so you feel powerful and you feel empowered to make maps and gather data and look at your community from that lens. And so hopefully, if you haven't used Community Commons before, you'll try and you'll be able to successfully make a map. If you have used Community Commons, hopefully you've made some maps and been like, that's pretty cool, I can do that now. So here's just a few examples of what they look like. Here I'm highlighting the map on the left is county health rankings data, and then the two maps on the right are 500 cities data. And so those are the two sources that you've just heard. The exciting part about Community Commons is you can take the 500 cities data or the county health rankings data and you can map it with other data. So you can look at maps side by side, you can look at poverty and county health rankings data, you can look at some 500 cities data next to housing developments or housing funding that's available. And so that's really the power that you see there and having access to not only our data warehouse, but then all of these other resources that we have within it. So The other thing that I always like to talk about, like I mentioned, is our map gallery. So these are just 2 maps that I pulled for this presentation from our map gallery. You're able to see maps that other people are making on Community Commons. So we currently have over 55,000 members on the site, and they're making maps every day and saving them. And for me, it's like a great place to go and get inspiration. I would have never made either of these maps. The one on the left is looking at broadband, and the one on the right is looking at solar and wind power sites. I mean, those are things that aren't really in my wheelhouse, but when I look at this map, I learned something and I'm like, wow, that's, that's pretty cool, and that's something I could share. And so I encourage you all to go to the map gallery and get inspiration from others and learn what other kinds of data are out there. So we also have the Community Health Needs Assessment, and again, that's why I said most people find Community Commons when they're doing CHNAs. And so we have lots of data in different formats for you to view within the CHNA. So here you're seeing a data table. We break things out. You're able to group counties or service areas within a report area and see an aggregate number for that. But then you're also able to get those county breakouts, which we know are important. So here we're looking at free and reduced price lunch within 4 counties here in Georgia. You can see that overall that report area isn't doing very good, but the culprits are pretty much 2 counties and the other 2 are doing better. So if you were targeting interventions, you would want to focus on those top 2 counties and not the bottom 2 counties. We also have some nice benchmarking dials that tell you how you're doing compared to the state and the nation, and then some editable companion maps that are always inset into each of the report pages. We try to break out the data by race and ethnicity when available, and if it's available as a trend over time. So if it's something that has been being reported on for a significant amount of time, we can show you trends over time, which we know we're all looking for. We wish all data was available, right, as trends over time. And then at the bottom of every page of our CHNA is source data and methodology. So if you're wondering where we got our data and if it's valid, you can always get back to the original source. We do also do small area estimates, so you can look at data at a smaller geography, so a census tract or a city level that's similar to what James was talking about from the CDC. Finally, we have 2 tools that I'm going to highlight pretty quickly: the vulnerable populations footprint. So the 2 biggest indicators of health that we think are educational attainment and poverty. And so that's what the vulnerable populations footprint does, is it hotspots those 2 areas. It looks at where the cross-section of low educational attainment and high poverty are, and it calls those areas vulnerable populations or vulnerable population footprint. So this is a pretty cool tool to use, again, if you're starting out a program or you're doing a grant and you want to justify that you are serving people that are actually in need. And then the kind of antithesis of that is our location opportunity footprint. So we always look at disparities, and that's not always a great way to look at your community. So we said, okay, we want to look at places of high opportunity. So we were able to work with the White House and some other really great data partners to find some opportunity data. And so this is looking at transportation, job access, and housing school proficiency is the other one. So it's looking at these indicators as opportunity indicators rather than disparity indicators. So where are opportunities high? And it's doing that same thing. It's kind of intersecting where those opportunities are high. So if you are looking to get people to, access certain types of resources, you can send them to these specific locations. So I think that's all I have, and I did it right. She just put my stop time up, so I feel good about that. Thank you all.
So thanks to all of our presenters, and just so this first segment was really this like data overview. So for some of you who are like, oh my gosh, data, here's how. It's the truth of it in terms of how to get the information you need to build your case. So I think what we'll do is just take a few questions on the data piece, and then we have a short segment on moving from data to action, right? So are there any questions that you have for one of us? There will be a chance to ask questions at the end also, but is there something like, can Community Commons do this for me? Or what questions do you have so that you can really use this to support your work? Any questions? Any burning data questions? The coffee, has it come on yet? You know? Yes, Jeannie. From Terrebonne, I know Jeannie, from Terrebonne Parish, Louisiana.
Bonjour tout le monde. Good morning. My question, I'm working with the business sector, and they're very much always wanting to get to the bottom line. And so in looking for economic impact, what can you advise me on the most efficient way to get to economic impact of obesity prevention or management, and how it impacts productivity, business, etc.? What data sets should I go to for that?
Here, like,
Is this on? Yeah. So I think that there are a couple of ways to go about it. So I don't know if there's any secondary sources right off the top of my head that I would direct you to, but I definitely would talk with like your local chamber and some other local organizations that you're probably already working with, like the health department, to see kind of what kind of dollars that they're spending versus, you know, what you're looking at in terms of outcomes. So oftentimes, you know, if you're looking at secondary sources, and the reason that I say I can't think of anything right now is that when you're talking about businesses, they're going to want something that's hyper local, and so finding something that is either on our side or that the CDC has isn't going to be very meaningful to them. So I would try to find data at a very local source if you can. And if there isn't data, I would encourage you to start talking with folks about collecting that data, because that's something else that I think more and more that we're seeing is people are realizing the gaps that are available or that are there, and that you are the ones that are going to have to make that data available. You can't rely on an economic data source at the national level to tell you what's going on in your community, which is probably not the answer that you wanted, but that's what I got.
But I'll add to that, I think that the National Chamber of Commerce is really starting to address the issue of the impact of obesity on local economy. And so they have some data, and I also where kind of Lift Up Prevention Institute does some wonderful data framing that can be helpful in terms of building this case that, not only in addressing obesity, but in addressing it for all, how important it is, and the cost. And I think it was mentioned last night also that we need to have this case built so that as we talk about obesity, that we're really talking about obesity for all, and build that business case. So I think that is important, and I'll give a shout out to Jeannie, because one of the things, and we were talking yesterday about partnerships, is she's working with a chamber-led health promotion project, so really using the business community to take leadership, to work with local coalitions that are doing work. So that whole thing of intersection, and how can we get out of our little worlds, we talk about cross-sector, how can we do that so that we really maximize some of these other sectors and resources in the community. So if there's not another question now, we're going to move to the section on moving to action, right? And many of you are going to be presenting about the great work that you're doing, but I'm going to ask Jamie to come back up.
You guys get to hear me one more time. All right, so moving from data to action. So I'm just going to talk about a couple of examples that we are close to at Community Commons about folks that have used our data to move to action. So the first couple of things that first couple of slides are focused on advocacy. So advocacy is kind of a scary word, and a lot of you guys are either part of nonprofits or public health departments. And one thing that I just want to say right off the top of the bat is that if you're not doing advocacy, you should be, and it's not illegal for you to do advocacy. So sometimes that's a misconception that you're not allowed to do that because you're publicly funded or a nonprofit, and that's not necessarily the case if you do it right. So Nonprofit Missouri is a group that I've worked with closely, and they were able to take some data from the Urban Institute and some other places to look at the economic landscape in their area. And so what they were trying to do is really make a case for the economic impact of nonprofits across the state. And what was really powerful about the report that they did and some of the supporting materials that they used, that they created on Community Commons, was that a lot of times you can get our data or you can see our data at a Senate or House of Representatives level, district level. And so if you're doing advocacy and you want to go talk about getting more funding or getting support from your legislators at a state level or even a local level, bringing the maps that show their state district and data within their state district is super powerful. And they're going to say, wow, and they're going to realize this is what's affecting my constituents and this is something I have to pay attention to. It's a lot more powerful than taking county level or state level maps to them and saying you should do something about this, because they're going to care mostly about what's going on in their district and making changes within their district. And so that's what Nonprofit Missouri was able to do with that report. So Salute America is another organization that we work with, and they are focused on preventing Latino childhood obesity. And so what they've been doing is they've been collecting policy changes around the nation. And so anybody who has implemented, and not even implemented, anybody who has started the process to think about policy change in their community, they've started to track all of those different policy changes that are either being thought of, being formulated, being implemented, and then those that are actually starting to produce outcomes. And you can see their policy map here. They have different policy topics, so active spaces, health equity, healthier schools, healthy weight. So they have this nice taxonomy that they're categorizing these policy changes into. But the cool thing is again, you get to kind of see the progression of those. So you can see whether a policy is just starting, whether it's been implemented, if it has any health outcomes associated with it. You can see that. And so that's a really great way to kind of start to, if you are making changes in your community and you want to show those outcomes, or you want to do some advocacy work and say, we're really making changes, give us some money or start to support us or whatever, this is a great model, and I would encourage you to kind of look at what Salute America is doing. This is a student project, so I teach a class at Washington University in St. Louis, and one of my students put together this map, which I thought was super powerful. And so what she was able to do was pull in condemnations, so housing condemnations in a certain area in St. Louis. And she was also able to pull in St. Louis City police data, so where crimes were happening in the city. And she had a hunch that crimes were happening in condemned buildings. And since the St. Louis City Police, they push out their data monthly about where crimes are happening, she was able to actually do this over time, and this is just one of the maps. But I thought it was really cool because she identified condemned housing where crimes were happening on a regular basis. And she was able to take that to property owners and to local aldermen and say, we have to do something. We cannot let all of these crimes continue to happen in these condemned housing buildings. And it really made a very powerful case for her to be able to show, not that it's just happened once, but it happens over and over and over again. And the data were able to really support her in that. So we also encourage folks to use Community Commons and data in general for program and population identification. Here, this is an example of the Community Health Partnership in Illinois, and they were trying to reach out to and provide services to migrant workers. And so they were able to use, this is predominant race and dominant spoken language data to say, okay, where are these pockets of folks that we know are coming in that are migrant workers that are in specific areas, and how do we get them access to health services? Their problem was that they're high utilizers of emergency room services, and they wanted to try to curb that and get those folks using FQHCs or community health centers instead. So they were able to use this type of data to locate some of those populations and do that. Finally, this is one of our like shining star communities that we work with, is Chattanooga, and they've done a lot in terms of using data to help support some of the work that they're doing, especially with program and population identification. So they have a mobile market program, and so what they were able to do is really map routes of this mobile market at a very granular community level to say the mobile markets need to go through this community and they need to make these stops because this is where it's walkable, this is where it's safe, this is where we can get people to access these fresh fruits and vegetables. And so they're using community commons to not only make those maps and those routes, but also identify other problems in the area. So they, because of the work that they've done, they've been able to put together some shared use agreements, again, the mobile market locations. They were able to map some childcare deserts, which I was like, oh my gosh, that's something I've never thought about before, but it's something that as a new mother, I realized is very prominent across all types of communities, that childcare is very hard to find and it's hard to get to if you don't have consistent transportation, and then also to support some trail projects. And so really they've been able to use the mapping and data tools on the commons to support a wide variety of projects. Now, by no means did community commons give them everything that they needed, but again, it just supported their work and was able to give them the justification in terms of the populations that they were trying to identify, and then also give them a nice visualization in terms of like, this is the impact that we're making, and they can take that to funders later. So I'm going to turn it over back to Mary, and she's going to talk about some additional actions.
Thanks so much, Jamie. As Jamie was talking, I was thinking the phrase, what is it? A picture is, I kind of get excited and I tend to talk right into the mic too loud, sorry. But a picture is worth 1,000 words, right? So I think that can be the value of being able to give people a picture of the things that you're talking about in your communities and the need for change. So quickly, sort of in summary, I just want to share some of the resources that we have on our website and beyond. And this is the Take Action Center. So one of the things that we do is really pull from all different communities work that you and others are doing and try to make it accessible to folks. So why reinvent the wheel, right? We don't have time for that. We need to be able to utilize what each other create. So on our Action Center, you can go here, and this is our what we call Action Wheel. Many of you are familiar with an image like this. But with each of these steps, whether it's the step of assessing needs or focusing on what's important, choosing policies, taking action, and evaluation, there you can click on each of those to get information and tools and resources and examples of other people doing this work to support your own work. And of course, in the center is, as was talked about last night, and I'm sure throughout this meeting, is at the center is the community, right? And how we need to shift our thinking so that the community is really at the core and use the community to help define the needs. So this is a great resource to be able to harness that collective power of leaders, partners, and community members. We also have community coaches such as me, and there are 11 throughout the U.S. And because of the support from the Robert Wood Johnson Foundation, you can apply to have a community coach work with the project that you're working on from 3 to 12 months at no cost to the community. So I'm used to working in the nonprofit world, so I'm like, this is a deal to take advantage of. And we talk about the community coaching as kind of guide on the side to support your efforts. We have the privilege of working with folks all across the United States. So it's like, okay, what's happening in Vicksburg, Mississippi might really connect to what's happening in Tampa, Florida, And so we're able to connect people with each other so that if one community is further along, link to help another community that's just getting started, and can lessons learned. I mean, always don't we want to, like, can't you just tell me before I start what lessons I need to learn so I don't have to make those mistakes? So that connectivity is a lot of what our work that we do as coaches. Also, this is a great resource. What works for health? So if you remember anything in terms of county health rankings and roadmaps and beyond our data, this is a resource because what this is a database of strategies, system changes, programs that are ranked in terms of have they been proven to be effective? So in terms of using evidence-based programs, policies, and systems change, you want to know if it's working or not, right? So here you can look, because many programs, like I said, and system change have been evaluated based on are they working. Now sometimes there's not evidence yet. So sometimes they're identified as lack of evidence, which doesn't mean that we don't need to be innovating and coming up with creative ideas, but just so that you know that from the start. And again, it's in our framework of health behaviors, clinical care, social and economic factors, and physical environment. So this is really a great resource. And in this menu of ideas, in terms of evidence matters, when you click on a particular search for a particular program, you can get the evidence rating, a literacy summary, who's done the work, so you can contact those folks, information about what the costs are, information about has it been shown to have impact on disparities, which is so important to the work we're talking about here, and also implementation examples and tools. So it's a really quick way to get some ideas and to find out what's working. So here's just an example. So here I just typed in obesity. There were 78 results. As you can see, I'm sorry, it's probably pretty tiny for some of y'all back there, but and so here it's scientifically supported, is multi-component school-based obesity prevention interventions, and I know there's going to be conversations about that, but here you can look this up and find examples. Also scientifically supported is the whole places for physical activity and really doing an assessment of what's available and try to help make more opportunities. Oops, I can't, so also in 2016, we did a special report on what works, strategies to improve rural health. How many of you are from rural areas? Raise your hand. Excellent. So you all know, as the data states, you know, there's really different challenges. So it needs different strategies. So we created this report to specifically address rural needs, and so that could be a great resource for you. So the foundations really, in terms of our county health rankings and roadmaps, is this the idea that it takes everyone, and the more that we use those and leverage partnerships and break out of our little silos, as all of you know, I'm sure, I'm preaching to the choir, right? But the more effective we're going to be at addressing these really serious issues of obesity that's killing people, right? And so how are we going to stop it? And we need to quickly move from data to evidence-informed action, and just how important that is. And focusing across health factors, really focusing on the social and economic drivers. High school graduation, you know, is one of the biggest indicators for the health of someone's life. and policy systems and environmental change. So this is just, when you get the slides, this is how to contact us and how to stay in touch. I also just want to quickly note that we do have a lot of other resources on the websites. We have webinars where we'll have like 2 communities talk about what they're doing in terms of obesity, or many topics, and it's a great way to get information. Maybe some of y'all are really good candidates for being guests on our webinars, so we always like it when you say, hey, how about doing this? The other thing I want to mention is also in 2016 we created a state health gaps report, and so every state has, you can look on the website and there are those health gaps reports, and so that's really a great resource, and especially this issue of being able to build your case, for all of us to build the case. It has some great information. So on that, I think we're actually on time. Questions? Any other questions in terms of the data or the action? And Dr. Parker, please feel free to come up and join me at any moment. But any questions or things that you know that maybe weren't covered, data sources that you use? You know, I love the idea. This is about learning and sharing. So, any questions? I'm scanning the audience. Yeah.
Very quickly, Jackie Jordan from Mississippi State Department of Health. So in creating those maps, is there a TA available for creating those maps?
On Community Commons? Yeah, so we do the same. We host webinars monthly, and so kind of just basic introductory webinars on how to create maps. If you need one-on-one support though, you can reach out to us at any time, and you'll likely get me or my colleague Erin, and we are happy to jump on like a go-to meeting and do a screen share and help you through that. Also, if you have data that you're interested in incorporating, if it's something that is finite and something we can pull in real quick for you, we're happy to do that on a like per data set basis if it makes a big difference in your work. So yeah, feel free to reach out to us. There's a support link or a contact button on every single page. You can reach out to us. So yeah.
Good news, right?
Yeah.
Yes. Karen Womack, State of Mississippi. I have a question for Dr. Petersen. Your coaching grants, Vicksburg got one. Thank you for mentioning it.
Yes. Vicksburg's doing great work.
I was just talking to one of those ladies today. But for those who don't actually get the grants, can we go to your website and kind of see what the other communities have done?
Absolutely. So
okay,
we
so
have community examples really throughout the website.
Good.
But also anytime you can contact via email or calls in terms of, you know, who else is doing this work? Can you connect me up with others?
Good.
So absolutely.
Thank
you. Thanks. Yeah. Good work going on in Mississippi. Yes.
Good morning. Thank you, panelists. Deborah Kibbe with the Georgia Health Policy Center. Dr. Holt, I'm interested in your feedback on when you think about the chronic disease indicators, and this might be a question also for Dr. Petersen. What are the things that in a 2-year window, you know, if we're trying to work with our state legislators and others, what are the measures that you believe we as individuals working at the grassroots level in public health should be looking at as we think about short-term or intermediate-term measures that we can use to influence decisions?
Well, the chronic, can you hear me? This is Mike. Okay,
You can come up here if they can.
Well, I think for chronic disease indicators, the thing to keep in mind is there's several different types of measures. So there's systems, environment, policy measures that talk about policies that are in place at the state level. They may not necessarily tell you how things are changing, but it could give you a snapshot of what policies and things are being measured at the state level that may have some downstream impacts on outcomes. The other part of the CDI that are probably good indicators of how things are changing are the health risk factor behavior-related measures. We do have mortality measures. They tend to be lagging measures, of course, hospitalization and morbidity, cancer incidence is probably the best indicator. But I'd say the health risk behavior indicators are the ones that are tracked every year. Of course, there is some natural year-to-year variation, but you can certainly use the data to look at trends over a period of time, and they are collected annually. So the data that you'll see on CDI, as well as other CDI, as well as other CDC state surveillance resources, are generally fairly up to date within the last survey year, typically.
And if I can just add to the $1 million question that you just asked, it actually is a $1 million question. So, for instance, the high obesity grants that I mentioned, Congress has given us resources to support counties in the United States that have obesity rates of over 40%. So we get that data from BRFSS. But what happens, and James mentioned that, is you can't use BRFSS for your evaluation of your efforts. So hold money back and work with somebody who's really good at evaluation at your local level. So you might have other measures to show. So you won't show a BRFSS change in 2 years of funding in a high obesity county. But if you have built out some evaluation efforts, you might have some BMI changes in a particular area or age group or target population for people who have voluntarily signed up to help you measure that. But it is a different way of thinking, and unfortunately many people start their project and then they get a year into it when they take their first breath because they finally got their staff hired, and they go, wait a minute, we probably should have talked to an evaluator before. So and you can call and ask people at CDC for ideas, or it sounds like these other great people as well, how you might do that. But it's a tough situation. Even measuring changes in physical activity or changes in access to healthy foods, even using the Healthy Foods Index, again, those changes are going to take a long time to see in the data.
Thank you. Yes, sir.
Hi, this is Duncan Van Dusen with Catch Global Foundation. Dr. Petersen, I'm curious to know, what are the most compelling statistics that you provide Congress when they ask about quantitative progress in the fight against obesity? And in the most candid terms you're allowed to use, what is the forecast for federal funding for this ongoing fight?
So I wish I had that crystal ball, because it would make my night so much easier that I wouldn't have to worry. And as you know, we have our Secretary of Health and Human Services resigned on Friday, so we actually need to have a little bit of time to figure out what our new priorities will be. Childhood obesity was one of Dr. Price's stated priorities. Don Wright is our acting secretary. Don knows our work well, and so we're happy that he's on board on a temporary basis. I don't have a clue about funding. So I will say that the REACH grants, the racial and ethnic approaches to community health, those are zeroed out in the House and the Senate and in the President's budget. So that's a $50 million program that's been in existence since 1999 that actually has no money that would be continued in the next grant cycle. We do feel like there's funding that can be in our core funding that was zeroed out in the President's budget, and it was put in back at the full amounts for stability in the House and the Senate budget. So for us, that's the bread and butter out to our communities and states, with the exception of REACH, which is a huge loss across the country, my personal opinion. What we show folks when they want to see value added is, again, we try to do what I just said. We try to look at some evaluation techniques we might have with those grantees at a congressional district level. So when we go to DC to provide information, which is what we can do as a federal agency, we bring maps that are based on congressional level findings. So it is really important to have those. We use WIC PC data oftentimes to show changes in childhood obesity over time and trends, and in the district level, which again we support. We're supported by our WIC partners. So you may want to reach out to your WIC folks and find out if there's local level on childhood obesity. Certainly your schools might have data you could use, but anything you can do in a district level is very, very, very helpful. And when we get questions, it's about what changes have you made in particular congressional districts. But it's hard.
Thank you very much. Could you please join me in thanking all the panelists for just before they leave, I wanted to ensure that you have as good instruction as possible in terms of what happens next. I'm going to invite Michelle Smith to say a little bit about the pillars, the kind of strategic pillars for this work. Because when you're done here, you'll have multiple rounds of smaller group conversations, and I'll explain a little bit more about that when she is through. For those of you who are counting, the word data was used 45 times, tools 13, community 36, and opportunity 7, just so that is right.
All right, don't want to keep you here too long. A lot of you have been here before, are familiar with the 7 pillars. We identified 7 pillars several years ago that were the key areas that can have the biggest impact on obesity. We encourage each state to work with all these 7 pillars, and we encourage you to attend the ones that most effectively relate to the work that you're doing. Early child care, schools, nutrition policy, food access, worksite wellness, they're all listed. Strategies that we have identified in the past that we thought would work across all of our 16 states are also in your program. So check those out. The pillar work groups are going to be a little more interactive this year. We're going to have more group discussion opportunities as opposed to having more of a reporting out situation where everybody just shares as a group. So we're hoping that we're changing the format a little bit to make it more useful to you. We will take the information that we gain from those pillars and send it back out to you after the conference. Also, I don't know if I mentioned earlier, but we will be sending the PowerPoints, or we'll be putting them on our website. They're not there yet, but they will be up there after the conference, so you'll be able to access all these great PowerPoints and all the information. I'm blown away by the information that we got and the opportunities you have about data. I hope that's making another connection. Tomorrow, our connection will be around communities. And I know it's a little late for this session, but there is Wi-Fi access. It is capital H Health, PIT 17, and you hook up to the SOS link on the hotel. So you'll have that repeated in the breakout sessions.
What did you say?
It's Health with capital H 17, and it's the SOS link, not the main Marriott link. So that's good in all of the breakout session rooms as well. Okay? And Chris, where did you go? Bye.
Thank you, Michelle. Just to reiterate, for the Wi-Fi access, because we know how important that is to life, your portal is the SOSGA. You'll have to probably scroll down a little bit to find it on your phone. And then the password is health, uppercase H, health 17. That should get you on. And if you are into Twitter, then at Southern Obesity, I think is the handle, hashtag SOSGA. All right? I have no idea what that means, but it felt like I was saying stuff that made sense. All right, so here's what will happen after this. We'll quickly transition into the sessions that are indicated in your program. So there are 2 sets of breakout sessions on either side of lunch. They're generally the same. I think in the afternoon there's a little bit of a swap out for the last one, Youth for Community Engagement. At lunchtime, which is at 11:35, you'll have the opportunity to either have lunch on your own, have lunch together, but we encourage you to probably participate in some of the lunchtime sessions. So you will also have the opportunity there to have conversation. Once the breakout sessions are through in the afternoon, then you'll have that discussion around pillars. And that's also outlined in your program in terms of where you might go, depending on the pillar you're interested in. And then finally, before we conclude for the day, there is an opportunity for our states to get together to talk. And that information is also provided. I would refer you to the map of the hotel facility so that you are aware of where the rooms are. For some of you may get your steps in, just trying to get there, but that's good. And I'm going to ask you at this time, if you could stand with me. Once again, you've been sitting for a while. For those of you who were here yesterday, do not worry. I'm not about to ask us to do anything bizarre. So we heard a little bit about some of the tools that we might use to help us in our work. And as you have the conversations throughout today, I'm going to encourage you to keep that health equity in your minds. What does this mean? How do you use these tools to get at folks having equal opportunity at health? What indicators or measures might be helpful to you, and what kind of data will you need in an effort to try and, as you deal with obesity here in the South, ensure that we have improved health equity? So I'm going to keep pushing that at you to the extent that by the time we're done, you really walk out of here with some solid ideas for action. One of the things I'd love for us to do as we go is just to kind of feel that we are one, given the circumstances. So I'm going to provide you with a rhythm clap and ask you as a group. I noticed that most of the rural folks were sitting in the back, not sure why, and there are other folks here in the front who I'm going to assume are either urban or suburban. And I'd like for us to clap together as one country. So this is the clap and the rhythm, and then on 3, I'm going to ask you to just repeat it all together, seamlessly, in sync. Not too hard. Here is the rhythm. Do it one more time. Do you think you have it? On 3. 1, 2, 3. Let's practice. Could we just do once more so that we can feel together and then make our way out of the auditorium? On 3. 1. A few instructionally challenged, but here we go. 1, 2, 3. Let's just go to break. Enjoy the rest of your day.